Well, welcome everyone, and I want to thank the SCCT for giving us this opportunity to present this morning, and I want to thank you for showing up so early, bright and early on a Sunday morning, last day of the conference. But first of all, shout out to the SCCT organizers. What a great meeting, right? So I've been coming here. I was telling the group when I got here 3 days ago that my very first SCCT meeting was in Montreal. And that was many years ago. I won't tell you how many years ago, but I think Joanne knows. She can do the math. But it was about 13 years ago. So I've aged, but the meeting has aged beautifully. So first of all, congratulations to the SCCT for this fantastic educational symposium. So my name is Dinesh Kalra, and I'm the Chief of Cardiology at University of Louisville. As you can guess, I'm a CT imager, but I'm also a multimodality imager, and my focus is on prevention and plaque prevention. But today morning we'll be talking about a little bit of a different twist. We'll be talking about the evolving aspects of CT, specifically on FFR by a company called Keya, which is based in Seattle, and it's a medical device company that does FFR, FDA approved. And then we'll also show you some data on new things that the company is trying to bring out, including plaque and other things. So I want to introduce the rest of my panel. Dr. Irfan Shafiq will go first. Dr. Shafiq is an eminent radiologist who has been doing CT teaching for over 2 decades. Is that right, Dr. Shafiq? He was associated with Johns Hopkins. He works out of Baltimore, and currently he is the president and founder of Forward Healthcare Consultants. He's run many companies in the past, but his passion is education in cardiac CT. And then we have Dr. Rumberger, who needs no introduction to this meeting because Dr. Rumberger is a master of the Society of Cardiac CT, was one of the OGs, as I like to call it, original gangster who thought CT would be valuable, and 2 decades later, here we are. He is currently the medical director and the director of cardiac imaging for Corazon Imaging, and clinically reads with a focus on cardiovascular CT on a daily basis. And then I'd love to have as my last panelist, but not the least, Dr. Scott Flam. So Dr. Flam and I have known each other for over a decade, and Dr. Flam has been prior president of the Society for Cardiovascular Magnetic Resonance, and that's how I got to know him. But he's a world-class cardiovascular imager who ran the program at Cleveland Clinic, and currently he's the Chief Medical Information Officer for Simon Med Imaging, as well as the Medical Director for Precision Image Analysis, and a Professor Emeritus of Radiology at the Cleveland Clinic Lerner College of Medicine. So fantastic to have such a great panel here. And with that, I'm going to turn it over to Dr. Shafiq to give our first talk.
Good morning, everyone. Thank you so much for coming this early at the very last day of the SCCT 20th anniversary. Actually, I remember when it was before the meeting, and me and Achenbach and many others, we used to meet for this cardiovascular imaging, and now it's 20 years have passed so much. First, I really want to thank you all for coming this early here and the last day, because I remember one time at ACC what happened. It was the last talk, and the presenter came in, and there was only one person sitting there, and he waited where nobody came, but he said, I had to present, he's one person I had to present, whatever. So he presented and thanked him for sitting, for that long and listen to the whole talk. He said, actually, I'm the next speaker after you. But anyway, thank you again. So 2 decades have passed, and as you know, there have been a significant advancement in hardware, software, AI tools, and all this has led to, from high CT resolution to ultra high resolution to super ultra high resolution. All you hear every day, and you can hear in the meeting also how it has improved the whole thing. And we have seen in front of our eyes what happened here. And that has led to innovative imaging biomarkers in cardiac CT. Those are the measurable indicators of characteristic of coronary artery disease that we can actually see the outcomes and improve the diagnostic accuracy of CAD. Now, especially in AI, I would really impress more on deep learning, which has revolutionized the cardiac CT analysis, and it has improved the imaging segmentation, quantification, stenosis, which is the fundamental application of machine learning analysis, plaque characterization, and identification of the culprit lesions, and also calculating the composite scores. And now eventually, we all know that FFRCT is the one which we can do the functional imaging too. So AI application has been used in reconstruction, calcium scoring, coronary plaque, and motion correction, epicardial fat attenuation with that also, and FFRCT also. So as you know, there are 250 shades of gray. You all know that. And human eye can only see what? 40 or less than that. You can't see more than, I know some of you are saying, oh, we have seen 50 shades of gray. I know that too. But anyway, so that's the thing which is, AI has helped us to really characterize the plaque and look at it. And now we can see the features of vulnerable plaque also very easily with the resolution we have these days, which really helps us also. And there are many studies done evaluating independent prognostic value of detailed plaque characterization in symptomatic patients. And PROMISE study showed that significant stenosis was associated with 9-fold increase in MACE. And when you adjust all the other factors and risk scores, the patient level presence of high risk plaque was associated with a modest increase in the hazard ratio also. And we have all learned in the meeting and before also the presence of larger low attenuation or non-calcified plaque burden nearly increases 5 times more likelihood of subsequent myocardial infarction. And this is more in actually seen in perivascular time, revascularization time, that these have a lot more MIs in these patients or cardiovascular effect. Nur Muhammad did really good studies, many of his studies, and they followed 10 years for non-fatal MI, stroke, and revascularization, all-cause mortality. And this was all AI guided, that's why I'm showing this. And they showed that stage 3 plaque based with the plaque atheroma volume was associated with composite outcome with hazard ratio of 3.5 also, besides the stenosis. So it's really something which is telling us, if you look at all the studies, a lot of studies put it together and look at the symptomatic patients and then the relative adjusted hazard ratio in these patients for cardiovascular, major cardiovascular effect, you can see the plaque characteristic in these different patients, what they have, and also stenosis where they stand in these patients. So everything really matters when you look at these plaques. It's just not the stenosis. We all learned that over a period of time. And if you put the clinical history, add the clinical history plus plaque burden, and on top of that you add the plaque radiomic phenotypes, that actually predicts better. Your prediction improves if you add these features on top of other things regarding the prediction of MI or other. So looking at the plaque and anatomy moving further to beyond anatomical assessment, the functional assessment also, as we all talked about FFRCT, which is the key tool these days in CTA. Everybody's actually using it quite a bit to identify the flow-limiting coronary stenosis and enhance their diagnosis and decision-making and further. So deep vessel FFR analysis, they use deep learning vessel, which is really those fundamental models which are pre-trained, and we use mostly multi-level neural networks which encodes all the functional and the anatomical characteristics in the coronary tree, and you can actually assess and evaluate CT FFR at any point in the coronary tree. And so multi-center machine registry found that there's no really significant difference, or it is comparable, the deep learning based FFR with any other method, which is computational flow drive based also. So, and also in some cases, actually, it turned out to be a little bit better because it learns as it goes on. And also, that FFRCT significantly reduces the rate of unnecessary invasive procedures and also less cost. It's been always, and the negative predictive value is really very good. So in the acute phase or in the ER, when patient comes to do CTA, it has very good negative predictive value. So there's very less likely that there'll be any major cardiovascular effect in the next 30 or 60 days. That has been proven also. So deep vessel FFR actually is a flagship product of Keya Medical, which is really a global medical technology company specializing in medical devices and deep learning. That's really the important thing. So the flagship product is deep vessel FFR, which was actually got all the approval from different regulatory commissions and got FDA approval in 2022. So what it is, it's very simple. What we do is load our images in a secure web portal and goes to the Keya algorithm where it's analyzed, and the report comes just like a 3D interactive report. You can do your own thing also with it, and also a PDF report for that to make decisions. So the study, which was ADAPT study, was one of the major studies where it got the FDA clearance, and sad to hear that Dr. Chef passed away, who was actually one of the authors and principal investigator in this study, and made the clearance so easy with this. We looked at the performance of deep vessel FFR in suspected coronary artery disease. The sensitivity, specificity, and accuracy was very good and passed clearance so easily with this. So other study was target randomized trial on-site CTF, which is really a lot of people say, well, we don't want to send the data out, but we will actually look at it on-site. And bigger institutions have bigger problems in that sense. They don't want to send any of their data out. So this was done on-site, where it says can improve the selection of patient. It's very safe and effective to select the patient who would or would not go for ICA or intensive or invasive coronary angiography. So advantages are that it is use less computational power, and this is one of the key things in all AI. The power usage is something really getting a big issue. Perform analysis in minutes, not in hours, minutes, and sometimes they're claiming it could be in seconds it can be done, and improves performance with more data. So more you let them learn the deep vessel learning, the more actually accurate it gets. It's self-learning, that's the thing in deep learning, what we found out. And so they have, I'll just show you a couple of cases quickly. And here in this case, you can see that there was a 70% narrowing, routinely went to invasive coronary angiography. They did FFR, which was 0.8. Retrospectively, did the FFR CT on this, turned out to be also 0.87 in this case. So this could have been avoided in this patient to send to have any invasive procedure in this case. This is another case. That's how you get the 3D interactive. You can put anywhere and wherever you want to see. This patient had wall motion and chest pain. You can see severe stenosis in circumflex. Lateral wall was really abnormal motion, and also LAD. And look at this, FFR was 0.52 in circumflex, and I think it was 0.7 in LAD. So he went for the next for the invasive procedure and revascularization. It's another patient who had left arm pain, tingling, exertional dyspnea, abnormal stress test, multiple risk factors, but he didn't want to take him to cath straight because he has been complaining this for a while, but they think, oh, it may not be the thing. But then we did the FFR. There was definitely significant abnormality in multiple vessels. So cath also turned out to be abnormal, and he went for cardiac bypass. This is another patient, shortness of breath, abnormal stress, and turned out to be severe stenosis in RCA. And you can see it was 0.5, and also in the other vessel, which was 0.7. So he also went for. So these are really, you can screen them well right away, whether he needs to go for invasive procedure or not. So machine learning models using kinetic plaque features for serial CCTA image shows the promise in predicting the risk of acute coronary artery syndrome also. If you use CT-FFR and all the plaque characteristics, that makes it further, improve your predictability, as we mentioned before in the thing. Now, this is a new study done just recently in UK, which really showed that implementation of a national AI technology program in UK and NHS, and which shows that it is feasible to do that, to have this, and it's very safe, and it can reduce invasive and non-invasive testing without affecting MI or mortality. So they had 100,000 patients, which is prior to CT, FFR, and after FFR CT. So there were 35,000 and the prior and almost 50,000 and post FFRs. And you can see that the significant decrease in non-invasive diagnostics. So the red is the post FFR CT. There's significant decrease in most of the non-invasive tests, except for MR, and that's been a little bit concerned. I was looking at that too. But again, all the invasive tests and everything have gone down quite significantly in these cases too. So it really improves in the whole community if you implement the AI. It's not easy to implement AI, as you know. There are a lot of issues, economic burden, and who will take that burden, to change the whole and uniformly apply everywhere the technology, and plus the power, energies, another thing, which is really everybody's looking into that too. But again, this was very feasible. Started with 27 hospitals, ended up in 54 hospitals. They implemented within 3 months, which is really interesting to know that. And also, if CCTA guided management in stable chest pain patients also actually showed that there's 10-year reduction in MI and coronary artery disease, death, and non-fatal MI. You know why? Because they followed up and their preventive therapy was boosted in these patients and that really helped as you move forward. So the Keya, the deep vessel product is deep vessel plaque, which is a software which analyzes data and provides presence and extent of coronary artery plaque and stenosis and disease. And what it is, the workflow is very easy. You send your seeds and your images, it uploads on there, and Cardicyte is basically triage. It tells you stenosis and extent of the stenosis and extent of the plaque, and then generates a deep vessel FFR from that, and also a deep vessel plaque report from that thing, where you can actually see the whole by just loading up your. And this is very, as you can see, color-coded severe stenosis, and also extent of the disease, how it goes, and it tells you all, and also give you the relative images also, which could be interactive also. And again, for deep vessel plaque analysis, the quantitative clarity of coronary plaque evaluation, which they give all the total plaque burden, give you low density plaque, and also non-calcified plaque and calcified plaque, and then the total burden and everything. And it gives you all these findings. And these are also color-coded to make it easy for you in that sense. And this is something becoming more, you will see more and more things are coming out, but it is more acceptable now as we are going through different studies, validation. Now, other marker, which is really, I think it's going to be something good, and it has already been, many studies have been out, that increase in perivascular fat attenuation index may be associated with higher risk of coronary cardiac death and poor clinical outcome. And this is also another product. These last two products are actually in the regulatory agency to be approved soon, and they'll be out in the market as we speak. There's also same in perivascular fat attenuation index in patients with diabetes. That also proved, that it shows that there's higher incidence of MACE in patients who have fat attenuation index abnormal. So it's been coming, and we can't, all these are markers, and these all are actually due to all this improvement in cardiac CT, plaque characterization, and CT resolution, and AI involvement in it. So that has given us now, so the traditional risk scores have limited accuracy for predicting MACE, as you all know now. I think at SCCT, everybody's a believer in that, and and AI solution contributes quite a bit in cardiac imaging, as we just mentioned here also. And also, there's advancement which improve plaque quantification and characterization, and also prognostic value across the population. As you saw, the new reports and the articles are coming out. And combining CTA and FFRCT with risk markers may improve MACE prevention, actually. It's very, it has been validated, and it's being validated as we speak, and we get more comfortable as more studies are coming out. So quantitative imaging technique powered by AI and machine learning are shifting towards personalized treatment, personalized data-driven treatment plan for coronary artery disease patients. Thank you so much. Appreciate for your hanging out here and lending me your ears at this early hours. Thank you so much. I would give it to
Next up.
next.
Thank you, Dr. Shafiq. Next up will be Dr. Dinesh Kalra. Then take us away.
Thank you. And just for housekeeping, I'll go now, and then Dr. Rumberger is going to show how he integrates deep vessel FFR into his practice, and then we'd love to take questions from the audience. All right, so I'm going to talk about a study that we performed. One of the things that I was really struck by in the world of CT is the fast pace of advances, as you heard from Dr. Shafiq, who did a beautiful job of laying the foundation of how FFR has become so integral in our practice. And as we see new companies and new technologies enter the space, I think it's incumbent upon us as cardiovascular CT practitioners to make sure we understand the relative importance and the relative contribution, and also look at diagnostic accuracies against each other. I think that's going to be really important in the world of plaque imaging, which is exploding. And I want to be the first one to say I think there's tremendous power in the shift from stenosis to plaque, but it's also really important as we delve into this to realize that, we have done our appropriate testing against our best available ground truths to make sure that the reports we're getting, we have trust in them, because we're going to manage patients based on those new technologies. So what we wanted to do is, when I moved to Louisville, we actually didn't have what was available at that time commercially across the country was HeartFlow. So I introduced that to Louisville. And at that same time, Keya Medical was coming out with their product, and I wanted to be able to test it out in our patients, but I wanted to do it thoughtfully, and I wanted to compare the relative diagnostic accuracies of each other versus a gold standard. And that's where we came up with the study, which we call triple FFR study. So it's, as the name suggests, a head-to-head comparison of both of those deep learning, non-invasive techniques, but with invasive FFR as your ground truth, the gold standard. And that study was led by one of our imaging fellows, Dr. Prabhakar, who's here in the audience, and also Dr. Khalik from Roslyn St. Francis in New York, who contributed data. So the background of this, as I've explained, is fairly simple, but all of you in this audience are well aware that current ACC and SCCT guidelines advocate for using non-invasive CT-FFR as a Class 2A indication if you have a patient with symptoms, stable symptoms, and your CTA read demonstrates that you have a stenosis of 40 to 90%. So you have two options. You could either do a stress test at that point if you don't already have a prior stress test, or, as many of you do, on that same data set, you could proceed with doing a non-invasive FFR derived by CT. And the reason we have gone down this pathway is because there's data from FAME. Now we have 5 and 7 year extension from FAME data, which showed that revascularization of lesions only gives your patients a benefit when you have an ischemic FFR in the cath lab. And then there have been extensive studies demonstrating the good correlation between CT-derived FFR and invasive FFR, which is how the CT FFR got into those guidelines. So this was the study from New England, where patients were randomized to get PCI or medical therapy once their FFR in the cath lab was demonstrated to be less than 0.8, and you can see that the hazard ratio is 0.46 favoring PCI in these individuals, driven largely by target vessel revascularization or non-fatal MI in those lesions. So with that being said, as I mentioned, at that time when we thought about and conceived the study, we had 2 FDA-approved CT FFR products that were available in the market, but no one had yet done a comparative efficacy and diagnostic accuracy study. So we wanted to do that to see where we stood with the new technology. So the methods, we had patients enrolled from our center at University of Louisville, as well as St. Francis Hospital in New York, where Dr. Khalik was the PI. And at the time that we submitted this abstract, we had data available for only 58 patients who were enrolled, it's not prospective enrollment, and I'll tell you why. The patients were enrolled. I want to clarify that the decision to proceed for angiography, invasive angiography, in this case, was made by the referring cardiologist who sent the patient for CT. These are often private cardiologists. We would provide them with the CT report. HeartFlow was just becoming available in our center. It wasn't universally available. And the decision to proceed for cath at that time, these private cardiologists were used to it at that time. They would just make a decision based on the CT plus CT plus symptoms. So it's not that the decision to move to cath was based on the ACC pathway, but we did have HeartFlow numbers for these people many times after the cath had been performed. And then, of course, we sent the studies for Keya, so we had both CT-FFR and deep vessel FFR values many times after the angiography had been performed on the same data set, which was sent out to the companies retrospectively. So, and as I mentioned, now we have many more patients. We have an additional center. We have a much bigger data set. So some of the data I'll show you was preliminary at the time that this abstract was submitted, but now we have data that actually looks even better, and it's going to be submitted for publication fairly soon. So the CTs were done in a standard method. Importantly, as you know, per SCCT guidelines, everybody received nitrates prior to the acquisition of the CT. And many of these patients were beta blocked. They were obtained with wide area scanners or a dual source scanner at both centers. And importantly, as I mentioned, the patients were sent for cath based on the percentage diameter stenosis read, as well as the symptoms that were perceived to require a cath by the general cardiologist. So these were patients who we took advantage of because they had already been going down the cath pathway, and we knew that the interventional cardiologist or diagnostic cardiologist, we instructed them that we were interested in doing this study. We were going to send the studies to HeartFlow as well as for deep vessel FFR. So wherever they felt it necessary to investigate, if you could please put a pressure wire down and get an invasive value so we can look at the comparative efficacy of these two technologies. And so these were done for lesions between 40 and 90% in segments that were more than 2 millimeter in diameter. And the vast majority of these invasive FFRs, as you can imagine, were done with instantaneous wave-free ratio. Today, there were a small percentage, perhaps about 10%, that were done with adenosine-based FFR, but current practice, as I'm sure in many of your centers, is to use IFR, which is wave-free instantaneous FFR. And the ground truth was invasive FFR, and we made sure for the data sets where we had three-dimensional displays, as Dr. Shafiq showed you, we had a fiduciary point of reference that was where we measured that non-invasive FFR was within 2 to 3 centimeters of the lesion, as the SCCT guidelines tell us. One caveat here is for the other center, we didn't always have our three-dimensional models. So we had to go by the report of what was reported, the abstracted data from the reports there. But for the deep vessel FFR, we had the models for all of these patients. So this is just an example. So somebody with a 70% stenosis on coronary CTA and a deep vessel FFR in that lesion is felt to be 0.79, and the patient went for a cath and had, in this case, an IFR done, which was similar, and ended up getting a stent, and then later the study was sent for heart flow also. And so in this one case, there's discordance, and I'll show you the data on agreement and discordance, as well as the relative specificities, sensitivities, et cetera. So our baseline demographics on these patients, we had 58 patients, and there were 87 segments of interest. So these are segments that are more than 40% stenosis. The majority of them, as I'll show you, had at least 50% stenosis on CTA. In fact, virtually all of them. The mean age was 64. Two-thirds of the patients were men. The rate of hypertension and dyslipidemia, what you expect in the high 80s. 40% were diabetic, a little bigger than what you see in most data sets, but we also live in Kentucky, where I think we're like third from the bottom in terms of all of these risk factors. And the majority of patients who were undergoing these scans were for either angina, as perceived by the cardiologist, or ischemic equivalent dyspnea on exertion. About 80% of patients were getting it for those reasons. And then if you look at the patients who had 98% of patients had more than 50% stenosis on the coronary CTA. So 57 out of 58 patients, so very few patients who were in the 40 to 50% range. But on the invasive angiogram, you'll see that the percentage of patients who had more than 50% stenosis dropped a little bit in the 80s. And so some of this read was perhaps because of calcium blooming artifact, where the stenosis was being overcalled on the CT, but we've known that in the early days when we didn't have FFR, that patients would get referred for cath based on an overestimation of lesions. And despite using deep learning noise reduction on our CT, that still is being seen occasionally. And then for the percent of patients who in the cath lab using instantaneous wave-free ratio, about 40% of these lesions were ischemic. And if you look at the patients who had ischemic heart flow FFR, it was about 36% of patients. And if you look at the patients with an ischemic Keya FFR, it was anywhere from, the number of patients was about 28%, and the number of segments was about 25%. Most of the lesions were in either the proximal or mid LAD. There were a couple of lesions in the left main, and of these patients, 24 of the 58 patients got revascularized, so about 41% underwent revascularization, and 5% underwent bypass, the remainder underwent PCI. So here are the results, and the first thing you'll notice is the agreement as well as the correlation is modest. So in terms of agreement of FFR CT versus invasive FFR, in this data set it was 0.61, 0.67 on a per patient level, which is generally always the case. The per patient data looks better than the per lesion or per segment data. And the correlation amongst the two non-invasive technologies was a little bit better in the 0.71 to 0.74 range. And if you look at the sensitivity for FFR CT, it was 71% on a per lesion level, 77% on per patient level, and for deep vessel, it was 60% and 68%. And the specificity was higher for deep vessel FFR in the 97 to 98%, and for heart flow in the 88% range. And the accuracy was in the 80 to 85% range, with an area under the curve of around 0.8 to 0.82 for both technologies. The one caveat, as I mentioned here, actually two caveats. One is that these patients were directed to invasive angiography based on symptoms plus CTA data only, not on the basis of FFR data, but we had the FFR data later. And the second caveat is we didn't have, at that time, the 3D models for all of these. And I didn't want to present to you the larger data set, which has still not been peer reviewed. So this is the one that is accepted for abstract, and we're showing this data. But as I mentioned now, that data is much larger, and the sensitivity on the current data set is quite a bit higher for both, and it's almost double the amount of data now. So in terms of ROC curves, you'll see that blue is deep vessel FFR, and red is FFRCT, and the sensitivity and specificity are, as I showed you, in the 0.7 to 0.8 range. And so our conclusions from this analysis were that both deep vessel FFR and heart flow FFRCT effectively assess the functional significance of coronary stenosis, and this aligns with the 2021 chest pain guidelines and the expert consensus statement on the use of FFR, non-invasive FFR. However, future larger multi-center studies are needed. Just like for heart flow, we have a lot of data with the advanced registry, the registry that Dr. Shafiq showed you in England with hundreds of thousands of patients. And so we need that extensive real-world validation to be done. So this was very preliminary analysis done only in 2 centers, and now we have data on 3 centers, but still quite a small data set. And we need to assess the clinical utility across various demographics and all kinds of patients, and all kinds of lesion types, heavy calcification, low calcification, poor scans, noise, artifact, all of those things. And really to test what is the impact of this on downstream outcomes in terms of testing. Dr. Shafiq showed you beautifully with the advent of FFRCT in the UK, how the rates of unnecessary invasive angiographies as well as layered testing with stress testing fell. And we would hope to be able to demonstrate that value for Keya also. So downstream resource utilization is important, but most importantly, downstream MACE is something we still want to collect. And so clinical outcomes are going to be also very super important. But it's good to know that, at least in a small data set, that the performance was non-inferior or somewhat equivalent to the current technology that most people are familiar with. So with that, I'll stop and would love to welcome Dr. Rumberger.
Much for this deft overview and comparison of techniques. And now again, Dr. Rumberger needs no introduction, and he's going to finish us up for this morning's session with some clinical perspectives and how he integrates data into care for his patients. Dr. Rumberger.
Thank you, Scott. Thank you very much for attending. I'm very pleased to see as many people here. As you may know, I've been doing cardiac CT for 40 years, so it's been a very interesting transition for me. And as I now function as the medical director of Corazon Imaging, I've had the pleasure to experience the use of DV-FFR in probably at least 3,000 to 4,000 individuals between our collective reading, between our level 3 teacher preventive cardiologist reading consortium along the way. So it's been a very good. We factor with 3 principles. Number 1, does my patient have cardiovascular atherosclerotic disease, not CAD, cardiovascular atherosclerotic disease? How bad is it, and what do I do about it? So all of our reports offer a consultation. So whether you're a primary care doctor or a referring cardiologist, you get the same opinion from us as to what we think the disposition for the patient. Of course, always leaving the clinician to make the final decisions because they know the patient best. So let me just go back here to understand that what I'm going to be talking about are things, even though I consider DV-FFR to be, frankly, the standard for this particular analysis based on my experience with them, but that's my personal opinion. But along the way, as a busy clinician, I need to take the information that I have from the DV-FFR and put that into the context of the patient. And I may use techniques that are not proprietary to Keya because as you continue to read the literature, you need to keep up with being able to especially respond to your referring cardiologist with the latest literature So frequently I will accompany this paper or that paper that's come out regarding our recommendations and information along the way, and in order to make them the undivided. So I'm basically talking about PCI in this particular case. There are so many other aspects along the way. But what I found is that when you look at the lesion, there are other characteristics that are very important for me to integrate into the information. So let's start with that. This is a PREVENT trial. It's a multi-center study done largely in Asia. Non-ischemic lesions looking at FFR greater than 0.8, as we consider less than 0.8 or equal to 0.8 as potential ischemia. High-risk plaque was defined by IVUS, looking at remodeling and looking at the presence of what they consider low-density plaque, or what you might consider vulnerable plaque, along the way. So they basically did this situation. It was a randomized trial where they said this guy gets a PCI, this guy does not get a PCI, and the one-to-one situation was published in Lancet just last year. So it's a very important situation. If you look at that, preventive PCI of non-flowing, limited, vulnerable plaque, again, FFR above 0.8, had a lower incidence of cardiac death, target vessel MI, ischemia-driven vascular revascularization, and hospitalization. And this was sustained over a 7-year period. So at 3 years, they saw the benefits of proactive PCI that continued out for the next 7 years. That gives us a lot of time to be preventive in terms of maximum medical therapy and pushing these situations together. The PREVENT trial, again, this is it. It was at 3 years, showed the benefit, but again, continued out many, many years along the way. There's another paper. This is looking at outcomes of non-ischemic coronary lesions with high-risk plaque characteristics on CCTA. So the previous paper looked at high-risk characteristics by IVUS. This one looked at high-risk plaque characteristics by cardiac CT. Again, they only included FFR above 0.8 and looked at that situation. Again, they have medical therapy versus PCI done at the angiographer's discretion. So that was just, if the doctor says this is what we're going to do, we're going to do it. Outcome, follow-up over 5 years, cardiac death, MI, revascularization. The important aspect here is basically to look at when you are below 0.9 in terms of FFR in the presence of a high-risk plaque or a potentially unstable plaque, that preemptive PCI was probably a better situation than to go and then, of course, do the maximum medical therapy, of course. That allows you to go ahead, get the major problem that could happen. And my philosophy is, you could say, listen, I'm just going to try a medical therapy. The fact is this patient may or may not have an MI in the next month, or may or may not have an MI in the next 5 years. I can't tell you that. I'm an aggressive person. I was trained by Mel Marcus at the University of Iowa. I always said to Mel, why do you have to have a cath on everybody? Because we had no other things like that. And he says, don't you want to know? And I go, yeah, I think I'd like to know. So with CTA, I get to know. So that was very helpful. So the two most common characteristics that you look at are remodeling index, which is very easy for us to visually interpret in terms of looking at the cardiac CT, and also looking at high-risk plaque features. Now, these are data that have been published by multiple situations, finding that any particular Hounsfield unit in a well-done study, less than 30, indicates the potential for something that is low attenuation plaque and potentially situation. So basically using things, I use Terra Recon, Vital Images has the same ability to be able to do these Hounsfield mapping. I do not know about vendor-specific software. I cannot address that situation, but it's a relatively common situation, so I will use that. We measure the lesion length, because that's very important to give the information, because anything that looks like it's a little bit longer than 12, 15 millimeters increases the risk of the pressure drop across those areas. So it also becomes important to integrate that whole aspect into that and looking at that situation. So when we have low density plaque, that's the one that I really talk about that's potentially a situation. So here's an example. CD-RADS 2.0, maximum stenosis was 3, which means 50 to 70% stenosis. Low density plaque was defined, as you can see here on the left, which is the image, and on the right is the Hounsfield mapping of that area. And then looking at the DVFFR and saying, listen, it's less than 0.9, it is not 0.8. Long-term therapy, I need to be able to advise my cardiologist that just want you to be aware that look at this. So I look at the vessel as a whole. I'm not just looking at whether the LAD has a obstruction and I'll say, okay, here's the problem. I want to know what's happening in the right coronary. I want to know what's happening in the left circumflex. And frequently that allows the situation. So even if we have a situation where I'm pretty convinced there's an obstruction in the LAD, it is my job to figure out whether or not there are other areas that I really didn't quite see that can give me more information about advising my cardiologist along the way. So another application is looking at the gradient, the change in FFR across the lesion. So this study by Hong investigated the prognostic value of cardiac CT-FFR gradient for future cardiac events. This is a retrospective study. People had CTA somewhere between 6 to 36 months before the cath. Coronary event was 181, and then they matched it with people who did not have any situation, did not have acute coronary syndrome with respect to that. The primary outcome was future events, vessel-specific MI or revascularization, and additive prognostic value of FFR gradient for PCI done for acute coronary syndrome. So the conclusions using CT-FFR for focal lesions, both FFR and gradient were associated with future cardiac events. Patients with particular gradients. Now, I will tell you that as you look at this, the literature, they're a bit nebulous about actually how they calculated these things. So what I've applied is just basically what I know with respect to that. But they basically said, again, that whether or not it's above or below 0.8, the gradient was the most useful information in determining whether or not this patient should be considered for PCI. So a gradient across the lesions showed that either with a FFR of less than 0.8 or an FFR greater than 0.8, but in the presence of an increased gradient, would be someone that does a little bit better with a preemptive PCI. So these situations are very important with respect to that, and I owe it to my clinical cardiologists that present to us to present them the information based on the literature that I know, that my readers know, in terms of the best decisions we can make with respect to these people. So here's an example. This is a lesion that was in the right coronary artery. It looks pretty bad, but it's not quite clear what's going on. The lesion length was 19.4 millimeters across that situation. So basically, just looking at lesion length, that would say that's probably a situation. But when we went over to look at the DVFFR, over here we had identified already in the LAD a reason to probably go to catheterization. But also it's important to point out to the referring cardiologist that there's other areas over here. So this went from 0.98 to 0.88 across 19 millimeters. So we talk about a gradient of 20 millimeters, which is an FFR of 0.8. We talk about this as an FFR, or loss of pressure gradient, of 10 millimeters of mercury, using that kind of situation. So as I said, they're a bit nebulous about it, but they said the gradient is the local pressure drop per unit length across the target vessel stenosis. So I took that information and said, let's take the information from going to 0.98 to 0.88 as 10 millimeters of mercury. Then let's go over the lesion length and come with that information. So that would suggest that this patient has a potentially important situation that the clinical cardiologist needs to know, may also be something to go after, in addition to what we already can see that the patient has a problem in their LAD. So my conclusions are, in good and excellent CTAs, we need to have a good situation. The application of simple Hounsfield mapping tool, looking for remodeling and looking for low-density plaque less than 30 Hounsfield units, in conjunction with DVFFR less than 0.9, can be useful in clinical decisions or clinical advice to the referring physician. Obviously, the decision is up to them, not up to me, but it's important that I give the guidelines, that I say, this is what I think. I think this is something you need to know. This is literature that you need to know. Also, in excellent studies, review of the color flow map allows me to get information about the gradient across suspicious lesions and to be able to integrate that information into the recommendations. Now, I will point out to you that in many situations, these are the equivalent of each other. I will find that the ones that have the greatest gradient are also the ones that have the lowest Hounsfield units. So it's something that it's not separate, but it's a useful technique to use. So, thank you very much.
Thank you, Dr. Rumberger. I see that we are drawing close to the end of our time, but wanted to entertain any questions that there were from the audience. Is there anything out here? While you're gathering some thoughts, Dr. Naubar.
Yeah, maybe just a quick question. How stable are these measurements across different CT platforms, different KVs, etc.?
Who'd like to answer that?
Plaque guy or
Yeah, I can answer that. So in terms of the FFR versus DVFFR data that I showed you, as we have expanded the number of patients we've collected, the sensitivity for both techniques is around 0.8, which I think is consistent with the prior literature that's been published. So there's less of a splay or a discordance there, and the agreement levels and the correlation levels are fairly good. In terms of plaque, as you're well aware, there's a guideline or a position statement from the SCCT, again, sort of cautioning people as new technologies come out to be very careful about the measurement of plaque, especially as it tends to happen in extremely calcified lesions or very small amounts of plaque. And I don't think the spatial resolution of CT today, with the conventional scanners that most of us are using, is good enough to sort out that boundary condition to be absolutely confident. Now, if you know, or I'm sure this audience knows, the correlation has been done in a couple of hundred patients for a lot of these technologies that are measuring plaque amount versus IVUS OCT. That's just a couple of hundred. And so really, I think that's an area that needs more caution and investigation. There's quite a bit of splay. I'll tell you an example from my center where we've sent a couple of same scans to different companies, and the delta between low attenuation plaque is as high as 40 millimeter cube. And here we are, if you look at the Reprieve trial, which used pitavastatin to look at change in non-calcified plaque, which all of us love to see, it was 2 millimeter cube. So I think we need to be very cautious as we incorporate these technologies that we're measuring the same thing. So I really applaud you for pointing that out. I think this needs further work in terms of inter-vendor comparison for plaque.
Thank you.
Mahfouz Shahawi, Sarasota, Florida. Epicardial fat have area of our interest for the last 20 years, both research and publications. Now, as far as the epicardial fat volume, it belongs to different category along the perivascular fat, have a different messenger RNA, epicardial as well as renal. Now, did you find, now you're talking about the individual vessels, because perivascular adiposity is generalized. Have you find a nomogram to tell you, for example, if the left anterior descending, so much is abnormal? So, because we have already nomogram for the total epicardial fat, 70 plus minus 20. Did you find anyone when you start seeing that's abnormal?
So we actually don't do that right now, but there has been studies where they show that it's very different in each vessel, how proximal they are, how distal they are, how far they are from the vessel also. So there are new studies actually going on where they're looking of not only perivascular fat, also in myosteatosis, also in the muscle, also in other, which is also shows, that how can it affect the cardiac failure and other diseases also. So
Have you
the
looked
data
at-
is coming out very, very, I see quite a few studies came out recently also showing that. But we personally haven't done that. But I always look at visually, actually, I do look at to see what is the perivascular attenuation and that's the thing I always try to use in some of the artifacts also. You have to be very careful that if the patient, there's slight motion, it will give you really some perivascular attenuation. So we have to be very careful in that.
Have you correlated with the renal? Because the perirenal is also the same messenger, RNA.
Yeah, but
Because maybe the cardiometabolic, cardiorenal may be the problem here.
and that is definitely a metabolic issue. That's exactly what it is.
We have another question.
I thought it's interesting the evolution of the whole idea of a gradient. That the gradient, even if the FFRCT is greater than 0.8, but the gradient of but the question is what about the interventional literature? Do they look at that?
Yeah, well, as I pointed out, there was the interventional literature in at least a couple of these presentations that suggested that the long-term outcomes were superior by looking at the gradient and doing the preemptive PCI rather than look and wait for these kinds of things. So
Yeah.
I can only use that to advise.
You're right.
It's
The question
very,
is,
very important, though, that we keep up with the literature because that's our responsibility
right.
as reporters. We need to be able to not only say, here's what you've got. It's not a cath lab report. It's, do you have disease? What do you do about it? What do I suggest you do about it? I suggest you look at this literature and see if it's helpful for your clinical decision.
I'd like to throw a last question onto that same, and I really appreciate the concept of the FFR gradient, and yet one aspect of it that I have a little hard time wrapping my head around is that number, that gradient that was proposed, is really dependent on the distance, on the denominator. And so my question, and we can understand if we have a greater distance that may underestimate that gradient. If we have a short distance, that may overestimate it. And so, is there a standardization? Is there something that we should do so that we have consistency in how that gradient is measured over a particular distance?
Yeah, excellent question, Scott. Frankly, I don't know. I go back to my cath lab mentor, David Holmes, at the Mayo Clinic, when he published in 2005 the finding that the gradient across FFR in the catheterization laboratory using invasive FFR, when the lesion length was greater than 10 millimeters, you need to start looking at the situation. When it's shorter, there's really no thing. So I look at the lesion length. 10 millimeters may be a little nebulous along the way, but if I see 15 millimeters, I'm pretty convinced that I need to look more carefully at that lesion and try to do that information. So, but there is no standard.
All right, seeing no other questions, I'm not letting you go yet. I've got one last question, and this is really to all of you. And that I think we are all blessed with this plethora of tools and data that's available to us in helping us really triage patients with atherosclerotic coronary disease. What I'd like to understand from all of you is that, do you have an impression, do you have a feeling, do you have a knowledge of what tools are most critical for us to use and what information is most critical for us to consistently put in our reports? You know, those of us in the audience who are trying to put these reports together, trying to do our best, are sometimes really inspired by all of the information we have, but sometimes a bit overwhelmed. And what is the pithiness that we need to get to in our reporting so we can help care for patients?
So let me take that. Yeah, actually, there's so much data, you're right, that coming out. And if you look at all these new softwares and everything, they already printed for you, data. The report is there, full report is there for you. And a lot of time people, what I see, they just attach the report, what it comes from the other side of the software, and say, this is your report, you can look at it and whatever. But I think personally, as the studies are going on and we're learning more over a period of time, I visually always look at the case and look at the clinical aspect of the patient and patient's age also. And then also look at the whatever lesion I'm seeing, how proximal it is also. That is very important to me, because the proximal the lesion is, now you have to be thinking more, what needs to be done. And all the studies have shown that no matter what you do, revascularize or not revascularize, end results are not changing much actually. The end product is not changing. So when I look at proximal lesion and I see non-calcified plaque and patient is younger, I'm really concerned about that patient. And I've seen people who have family history of early coronary artery disease and if I see any soft plaque or anything, I always mention that the lesion is proximal, and I do see a non-calcified plaque, which is I'm more concerned about it. And so and I discuss the patient with the referring physician actually, that I used to do a lot, less now. I just put it in the report because cases are increasing. Before we had time, we could do that. So those are the things I really visually pay attention to, besides all these plethora and tons of numbers coming at you at every case. When you do Clearly, you do other all these softwares and heart flow, everybody's doing their plaque and other thing. But I think you still have to focus on your visual regarding the clinical history. So it's very important when I order FFRCT, when I don't want to order FFR, that's also important. And it's not you order everybody FFRCT, and that puts you sometimes in trouble also. Sometimes we say, who ordered this test, patient? Now we have trouble, now we have to do something about this patient, when patient can be stabilized otherwise quite significantly. But the data is showing that it helps in prediction of the MI and long-term MACE effect too. So that's my personal how I take it. But again, always be confident of what the data is coming out of these softwares too.
Yeah, I love what Irfan said. Calling up the referring doctor is very important. Unfortunately, many of us don't have the time, or we're not in sync as often these days to sort of exchange that information. But I do want to, as most people in this audience know, the SCCT and ACR have really led a very concerted effort in terms of reporting structure and key elements of what needs to be reported. The workhorse of CT has always been reporting calcium scores as well as percentage stenosis, and then classifying it in a very standardized format these days in terms of, what is potentially obstructive stenosis, and when you have followed up those things with non-invasive assessment of physiology. I think the challenge before us today is, as we mentioned, we're getting a plethora of information on plaque. And that's where you can really overwhelm the referring doctor with, if you give them 300 numbers of all kinds of plaque volume on that report, it can be a little dazzling. And so the SCCT has again incorporated plaque scoring qualitatively on the report, and I think that's really wonderful. But for the people who are preventive, we need to take the Scott Hart data to our advantage and report that even though they may not be obstructive disease, this patient has extensive atherosclerosis, and then the SCCT and many other societies have followed that up with treatment suggestions and guidelines. So we put that in there when we put the references in there so that the referring physician knows the guidelines and what to do. I think those are crucial elements.
I find that the most useful thing for me to do is to look at the lesion length of the situation, good vessel to good vessel. Report that information because the lesion length, I think, is a big significant integrator into my decision making. Despite all the issues about plaque volume and all these things, I personally feel that it incrementally is limited above what I can get with an estimation of looking at the calcium score. That allows me to look at what it is. There are guidelines that have been around since we first wrote them back in 1997 about what to do with the situation. And I think that it's not just the plaque volume, it's the plaque characteristics that I'm most interested in terms of the things that I talked about with high risk. And I think the future is really going to be in inflammation mapping. That's going to be, I think, the final situation for us to be able to say, this is not only a high-risk plaque, but also the perivascular inflammation is really much higher than I would like to see. This patient needs to be aggressively combination statin therapy, PCSK9 inhibitors, Lovaza, colchicine, GLP-1s, whatever it is. We're going to make these kinds of things forward for our patients.
All right. Well, I think we're going to wrap this up. I think this room needs to be used elsewhere or other purposes, and we've overstayed ourselves. But I thank all of you, and I thank all of the speakers for a terrific session, and thank you for all of your questions and rapt attention. And hope you enjoy the rest of this fantastic SCCT meeting. Thank you.
Thank you so much.